it was actually just last year when the government published the Health General Practitioner Services Act that introduced the framework for the rollout of this policy of free GP care for everyone, but beginning with the under sixes. And when it was announced, it had quite a mixed reaction. I mean, on the positive side, people said, fantastic, at last, all of the children, at least an additional 270,000 children would benefit from free access to GPs. But there was a lot of negative comment, mostly from the medical profession. A lot of, for example, the IMO said that they were appalled at the system, and others looking at the pressures already on the healthcare system, primary healthcare system, said things like this will cause chaos. And initially, GP unions rejected this program and said things as well. Nobody's going to sign up for it. None of the doctors will sign up for it. But again, by the end of the year, just over half of the GPs who were already signed up for contracts had joined. I think by now there's, something like 70 to 80%. It depends on where you're reading it. So what is this? What is the effect likely to be? So you think that there's other countries who have this system. Our next door neighbours, the UK, have free medical care. So certainly we should be able to find out what pressures that has on their GP services. But they've had that for a long time. New Zealand only a few years ago introduced free medical care for the under 7s, and they're now extending it to the under 11s. We thought, wonderful, it's so easy. Just go and look. Somebody's bound to have looked at what effect giving free medical care to a very specific group of people will have on the use and the demand for services. But when we actually did look, there is actually a lot of information about the use, demand, eligibility, accessibility of GP services, but most of it is done for a population as a whole, or just an adult population. There's very little specific to children. Even though we look at children as a very special group when we're looking at healthcare, when we actually have a group of illnesses we're called childhood illnesses. We spend a lot of time looking at early development, and there's a lot happening in child's development, psychologically, physiologically, anatomically, from the age of 0 to at least 5, 6, maybe even until 10, and then you enter a whole lot of different ballgame when it comes to health issues, medical issues for children. But so, how useful are these adult studies, and can we actually extrapolate from these adult studies to what is actually happening to children? So we thought, well, we do have a wonderful set of data, the Growing Up in Ireland study. So we should be able to use that to look at what the potential impact would be. And I like this, doing this now, because this is before it happens. And so can we come up with a model that in future years, 5, 10 years, we go back and say, look, yes, we were actually able to predict using this data set, using these methodologies, we were able to predict what did actually happen. Now, it's not as easy as there was no free care, now there will be free care. In Ireland, there are 2 other avenues of access to free GP care. The first one is a medical card. The medical card gives you lots, not just the free medical card. We have nominally free prescription medicine, well, after you pay the first €2.50 for each item. There's also free dental, optical, oral services. You also get access to maternity and infant care, community and social services, public hospitals, public health nurses. And there's also another issue, other services such as free school travel. You get exemptions from paying school books. You get exemptions from paying fees, exam fees in public schools. I'm not quite sure how they got linked to the medical card system, but they are. And then there is the GP visit card, which, that's what it says on the tin. You have a GP visit card, you can go to the GP for free. Now both of them are set, start with medical card, it's income dependent. So it's nothing to do with your health status. It's income dependent, based on the income of the adults, then adding in other factors for the number of children. And it's set on weekly income relative to family size. And there are a few other issues that we take in, like mortgage or rental payments, travel to work, childcare payments, or costs. And it is actually earned income and savings. So a lot of state benefits, social benefits, like disability allowances, etc., aren't included in this. The thresholds for the income are set nationally and usually reviewed annually. And if the people who are making this decision whether you qualify or not decide that if you don't have a medical card, that it will cause undue hardship, they can issue a discretionary card. And if you don't qualify for that, then there's the GP visit card. The income thresholds are set slightly higher, and again, if you don't meet the eligibility rules, again, they're based on income. The discretion there is if not having it would be unduly burdensome on the family. These discretionary cards, there are not a lot of discretionary medical cards out there. So I think 2012, looking at all the cards in issue, about 5.5% of all cards were discretionary. So in effect, this new system for the under sixes is not actually a medical card. No, it's called the free medical card for children. It is actually, when you look at it, a free GP, the GP visit card. The eligibility thresholds, basically if you are, let's see, married with children, this 266 is the starting point. Then they add in, for the first 2 children, it's something like 38 euros per child. Then the third and subsequent children, it's slightly lower, it's 42 euros. And then you add that, that's the allowed income. And if you're below that threshold for your income, you're eligible for the card. If we look at, this was the 2003 figures of the cards issued in that year, you see that about 10% of the cards are GP visit cards. It's interesting to note we haven't been able to understand why the difference is between male and female children, because these cards are issued, the medical cards, GP visit cards, are issued to families. If your income makes you eligible, everybody in the family gets access to those services. For discretionary cards, they can issue that card to an individual or individuals within the family. So you may find that in the discretionary card there may be one, for example, a child that has a particular illness will have the card, but the rest of the family don't. If you want to know more about things, what unduly burdensome and hardship is, I do have some information, and again more on the thresholds and what the criteria are for getting it, not getting it, how long you can have it for. For example, you can keep it for 3 years after you start work. So it's not as clear cut as income threshold. If you have it, go above that, you don't. There are lots of other nuances to it. But if you look at the trend, here looking from 2002, the trend is increasing. The GP visit card was introduced in 2005. And again, you see the numbers there, a little bit at the top. It is actually increasing as well, but it's still less than 10% of the cards in issue are the GP visit cards. Currently, 1.8 million people, i.e. 40% of the population, are covered by medical cards. And only about 400,000 have the GP visit cards. So, when we get back to what are people saying? There is a certain body of literature. You can see the first studies there's quite a lot of information about GP usage, availability, access, need in Ireland. But again, it's all based on adults. And then if we look at the bottom one, where we have some studies on children, in the literature you'll find that how we define children varies. For some people it's 0 to 5, 0 to 7, 0 to 1, 2 to 5, 0 to 15, 0 to 17. So even the definition of what's a child is kind of fluid. And again, the studies, there are some of them are actually specifically. This one was actually specifically done for these. This is actually 3,000 children in 3 different Nordic countries. So they actually specifically for this study. Others are using data that's collected for other purposes and then using it to look at either access, eligibility, use of. There are a few that actually do then specifically look at children. There was a study that was done in Australia in 2003, and it was basically focusing on just the first year of life. And they were looking at a number of different primary care services. One of them was GP services. But they only found a sample of 173. There has been a study done in Ireland recently by Dr. Bain, and again looking at he's trying to estimate the impact of this new service on the under 6 from the GP attendance rates. But again, it's a study of just 6 general practices in Ireland and only just under 2,000 children. There was also a study again looking at consultation rates in the UK. This wonderful database, Q Research database, was set up in the University of Manchester. It has data from the NHS from 1995 that is supplied to the university on a voluntary basis. I think they now cover all of the different medical practice areas in the UK because their health system is organised very different from here. But if you look at the data from 95, it covered 1 million registered patients, and now they have records for 2005, 6 years records for 4.3 million. So it's a very large database. So again, just from all of this, what are the key findings from these studies that relevant to the introduction of free medical care to the under 6s, free GP care, sorry, under 6s? Well, the study that Anne Nolan did in 2012 using 2007 data, basically she found that trying to interpret some of these results was quite complicated because what she considered to be pent-up demand from the introduction of the visit cards 2 years previously. So 2 years later you're still seeing from such a small difference, so there's so few of these medical visit cards being given out, that if 2 years after there's still evidence of what she considered pent-up demand is it likely we're going to see a level of pent-up demand in the introduction of this current system? So when can we look and decide that this is now settled down and this is normal consultation rates? Most of the studies, the findings were that need factors were based on age and health. And again, the second study on that was from Anne Nolan from 2008. She found that looking at Ireland, it was actually based on health status and medical card eligibility. And again, now that so many more children will have been eligible for free doctor's visit, could this then drive demand, as the doctors are saying, would be an overuse of the system, or to a point where the system can't cope? In the 3 Nordic countries, they were looking at different socioeconomic groups, and they basically found that there was very little difference between the demand for GP services and income. Now they actually found that there was no significant, but the largest difference was mother's education. It was even larger than income. So maybe there's some other factors we need to add in if we want to look at what the demand for healthcare will be when it's free. The study that was done by Leighton Nolan, looking at, there's a study similar to the Growing Up in Ireland study, there's the Growing Up in Scotland study, and they were looking at inequality in use, income-related inequality in the use of GP services. In Scotland, because it's free to everyone, and has been for a long time, they found that there was no significant inequality. Slightly different in Ireland. Now, the terminology pro-poor, pro-rich was from the report, so I don't want to, because I don't actually know how they assigned and what actually made up a poor or a rich. I don't actually have the actual definition. But basically, when you look at the whole of the Irish system, it was seen to be pro-poor. And yes, we can see that there are, if you have low income, you can get free access. So it is more geared towards those low incomes. But when they took that out and they looked at just those who were paying for the service, then it would seem to be more pro-rich. So maybe there is a group of people who are not using the service for reasons of income. So maybe we will see an increase in demand. Very interesting was a study from Australia, but bearing in mind it was a very small sample size. In the first year, they found that the average number of GP visits was 10.9, which was extremely high. And more importantly, and I think also more salient for the current system we're introducing in Ireland, is that the majority of them were unrelated to illness. So it's people coming in and maybe the child isn't sleeping at night, or somebody else's child is walking and mine isn't. So a lot of other issues coming in to do with child development, not illness related. This study from Ireland done by Dr. Bain, he looked at the average consultation rate of 3.1 for all of the under sixes in their practices. But then when you divide it up into medical cards, the GP visit cards, and the private or the paying patients, he found very different rates. And if you look at those of the 4.9 to the 5.7 and compare them to the growing up in Ireland of 3.19 and 2.32, and then in Ireland there's also from the quarterly National Household Survey, every so often they do what's called a special report, or a special module. In 2010 they did one on healthcare, and they were looking at the average annual GP consultations and that. But again, that was for the population as a whole, and that was 3.2. Dr. Bean suggested that these results from these two studies indicated that as these were self-reported, so they asked people how many times did you visit, that there was an underreporting bias. So he was going by the records from medical consultations, the actual number of visits, as opposed to people's memory of how many times they want to visit. But then we look at the UK study where they looked at the general household survey and matched that with the actual consultations. We found something quite different. So here you have what the GP said for males, females, which is quite interesting, as the actual number of visits from under 5 to 15, right up to 75 plus. And then from the general household survey, which is the self-report, they actually found that there was an over-report. Now, I presume, of course, it's parents that are reporting for the children on behalf of the 0 to 5s. I'm also interested, I'd actually know more about this as well, as to why we get closer whenever children are between 5 and 15, when there's a more accurate reporting. But they were actually finding an over-reporting. So, does this have implications? Reporting bias. Well, basically, if everybody's over-reporting or under-reporting to the same degree, then it shouldn't really have any implications or no impact. However, if there is a differential in the under-reporting, depending on payment or non-payment, and there's a lot of literature that says various reasons why we under-report. For example, if you have fewer visits, you're more likely to under-report. You're more likely to be more accurately reporting than if you have a lot of visits. You know, was that 5 times or 6 times I went to the doctor last year, or didn't go or just went once? There's a lot of literature that says, it's more to do with you go to the doctor, nothing exciting happens, you say let's go away and you get better soon, or I had to go and see a specialist. You're more likely to remember that. So is it the outcome? Is it the number of visits? Is it the fact you had to pay or not pay? So maybe you're more likely to remember because we had to pay for it and more after reporting, so maybe you should actually be payment rather than the non-payment. So the reporting bias is a very interesting area, and I think at this point, before I get carried away on reporting bias, I think I should hand over to Kevin to actually tell you more about the analysis that we've actually been doing on the data that we got from the Growing Up in Ireland.
Okay, so I'm going to talk about the numbers. So we're going to estimate count data models of GP visits, and we're going to progress in a fairly standard way. We're going to use mostly Poisson regression. There are kind of two components to a Poisson regression. First of all, you have what's called a Poisson point process, so it's an assumption about how these events occur, and you get this strange looking thing that may not be familiar to you. This goes back to the early mid-19th century. Famously first used to model the number of soldiers kicked to death by horses in the Franco-Prussian War. So that's a kind of just a general statistical process, and then you complement it with a model of the mean, or sometimes this is called the intensity parameter. So we're going to make that a function of x prime beta. So this is where our variables are coming in. These are the slopes, and this is the exponential function. And that's because the thing we're modeling is non-negative, right? But counts can only be 0, 1, 2, 3, 4. Okay, so this constrains the fact that you're only dealing with things that are non-negative. So 0, 1, 2. A consequence of this model, a well-known consequence, is that the mean is equal to the variance. And that can be problematic because typically the variance is greater than the mean. This is what's called over-dispersion. So one solution to that is a kind of a generalization of Poisson regression called negative binomial. So that avoids this, or it kind of generalizes this, but it keeps this. So the interpretation is much the same, but the kind of details of how you calculate it are different. Although that solves one problem, it also kind of introduces one, because it's more sensitive. The negative binomial, neg-bin, as we call it for short, is inconsistent if your assumption about the variance is incorrect. Whereas Poisson, the nice thing about the Poisson is, as long as this assumption is right, your model is consistent for your slopes, but you need to do something about the standard errors. Okay? So the Poisson assumption is wrong up here, but that's right. You can estimate it, but you need to correct the standard errors using what I call robust standard errors, or white standard errors. How do we interpret these things? The beta is the parameters that we're going to estimate, we call semi-elasticities. So it's going to be the effect of a change in the variable. It's going to be the proportionate effect of the change in the variable. You might also be interested in the marginal effect. In other words, this is the effect on the proportion of doctors' visits. But you might want to know just how many extra visits. And that's easy enough to calculate. It'll be just this parameter multiplied by the mean of y. So in general, we're going to report both of these. Now, the variable we're interested in, the medical card thing, is actually a binary variable. So you can't, strictly speaking, differentiate with respect to it. You just take discrete changes, right? So we'll have a dummy variable and we'll switch it on and off and see what happens to the expected number. So there are countless other estimators for count data. One issue that pops up with these models is what's called excess zeros. You get kind of too many zeros, more zeros than you would expect in such a process. This could be for a number of reasons. Some could be just in the particular period that people were asked about, they had no visits. So there are a couple of ways of dealing with that. Basically, kind of two-part models, what are called hurdle models, or zero inflated. These are subtly different. And so basically, you kind of have one process explaining the process at whether you no visit or one, and then you have another model for the continuous variable.
Sorry, I don't understand your motivation for excess zeros in this case, because it's annual data you're getting estimates, right? And what the expected for something to do after 3 years. They're going to be manually doing once, right?
So, well, you'll see the data. This is just a general comment about, I haven't said, so your question is actually irrelevant. I'm just saying.
Well, maybe this presentation is relevant.
Yeah.
If you're
Yeah. So if you just wait a few minutes, you'll see.
Okay.
So there are other ways of dealing with it. It's a thing called finite mixture methods, which is related to something called latent class models. It's kind of a special case of that, where you assume that the process is kind of like a weighted average of different functions which are explaining different parts of the distribution. And that's quite a nice approach. When you go to panel data, you have much more limited options. And there's basically panel data models for Poisson models and to a lesser extent for negative binomial. And we're going to be looking at panel data, so that's going to constrain us. So for the panel data models, now we've got two subscripts, I for individual and T for time. And the main thing to think about it is we're going to allow for an individual specific effect, typically called alpha I. So this is the same as before, but now we have an individual specific effect. And sometimes it's written like this, right, where delta is just log alpha. And the way, so here it's written as a multiplicative term, here it's just rewritten as additive, because you can think of this thing as adding, this is the single index. One of the nice things about the fixed effect Poisson process is there's no incidental parameters problem. So if you're estimating panel data models for certain limited dependent variable models, like probit and logit, you might just think, oh, well, I'll stick in the fixed effects like I do with a linear model. But then you run into this famous problem, incidental parameters, go back to paper by Neyman in 48, which is that you can't get consistent estimates of those parameters. Because as n goes to infinity, you just have one more parameter. So that's a real problem if you're estimating probit, logit, and tobit. But it's one of the nice things Lancaster showed that this problem doesn't exist here.
Why doesn't it exist here? Is it just different out somewhere?
Yeah, because basically you can condition out the alphas and solve them out. So the way you estimate this model is you solve out the alphas and then concentrate the likelihood function. So you get what's called a concentrated likelihood function. Now the marginal effects that I talked about earlier will depend on these alphas. So there's basically two things you can do, and we do both. One is just look at the semi-elasticities, right? Look at the betas. And they're of interest in their own right. Or the alternative is to say, well, let's evaluate these things when delta is 0, when all the deltas are 0, which is the same thing as saying when the alphas are 1. Panel data for negative binomial can be done. It goes back to a paper by Jerry Hessman and et al. It only seems to work for the negative binomial 1 case, and it's kind of messy. So we're just going to talk about fixed effect Poisson. I will show you some neg-bin.
So I guess the naive question is, why not just do OLS here? I know you know it's negatives and it's calculated and all that, but if you're interested in conditional mean, that's what regression will get.
Well, we're still going to be telling you about the conditional mean.
Right, but I guess even as a specification check, sort of it directly gets you effective X on the mean. Well, all this will sort of indirectly get you with like sort of use a non-linear thing, and then
Well, it's not very indirect to me. It will be these squares.
But if I just want to know what's the effect of negative part of the mean, these squares will tell me.
Under the correct specification, if the Poisson assumption is correct, then these squares will be inefficient.
Oh, yeah, I'm sure it's.
Yeah.
If the Poisson's not accurate, then eating the consistency.
No,
You're gonna have
they
more-
get the consistency estimate of the slope.
But not yet.
I don't think we've done the OLS. Well, yeah. So a big deal here. So the Poisson versus negative binomial is not a big deal. I'll show you that. Fixed versus random effects is a big deal. Any economists in the audience will know that economists generally go for fixed effect models because we tend to assume that these individual specific effects, these alphas, are probably correlated with some of the x's. So the alpha is your, if you like, unexplained heterogeneity that makes you go to the doctor more often. And we think, well, maybe that's correlated with some characteristics. So that's why we worry. So fixed and random, of course, is terrible terminology. It's really correlated and uncorrelated, more accurate. If they're not correlated, then it makes sense to do random effects, and that's more efficient. And people in kind of biostatistics tend to use random effects. They probably think we're nuts for doing all these fixed effects because we're throwing away a lot of efficiency. But in economics, we have this strong, I suppose because of the models we deal with, we just tend to automatically see these correlations, and we think these correlations are plausible. With fixed effect models, the identification of a variable comes from the fact that that variable changes. Right? So in this case, it would be switchers, people who switch to having a medical card or to losing. Variables that don't change, so people's health doesn't change over time, are not identified. Now, strictly speaking, what I've said here is only true for the Poisson model. It's actually not true for the little known property of the fixed effect negative binomial, that time invariant variables are identified. So the data we use is growing up in Ireland, the infant cohort. Last week's seminar was on this, and other people have gone on about it, including myself. So I'm not going to tell you too much about it. We used the first two waves when they were measured happened at 9 months, that was between these dates, and wave 2 when they were 3. Wave 3 is been collected 2 years ago and has not been released, long overdue, major pain in the neck for those of us who would like to use it. So what do we do? So the dependent variable is based on the question that the primary carer was asked. Primary care is nearly always the mother. And she was asked, since baby was born, how many times have you seen or talked to the GP on the telephone about the baby's physical health? So she's asked about GPs, consultants, nurses, a bunch of healthcare professionals. The only difference is in wave 2, she's asked in the last 12 months. Right? Obviously, in this case, there wasn't the previous 12 months. So this is a standard issue in count data models. What's called exposure or offset. So it'd be like if you were measuring, you're counting the number of raindrops in a bucket, you would have the fact that the surface area is twice as big, in fact, twice as many raindrops. Effectively, what you do is you assume that the frequency, the number of events, is proportionate to time, so that the rate doesn't depend on time. Controls. So we primary carers' economic status, whether their labour market status, their sex. Again, 99.8 are female, but we put in a kind of a dance dummy. We have 2 variables, categorical variables on their health, their age at school, the child's sex, whether they were born abroad, whether they're covered by private insurance, and just whether there's a man about the house, basically, or a partner about the house. Household equivalent income, quadratic, and the number of people in the household. Now, this is not a definitive study of all the things that could possibly affect this outcome. And in a data set like this, you can find more. But our experience is, having experimented a fair bit, that you can find variables that kick in and that may be of interest in its own right, but our results are very robust. So it doesn't really change the results of interest.
It's not worth looking at, say, the number of people in the house, distinguishing between the number of siblings and the number of other adults. Right.
Yeah, I mean, we have, well, given that you have a partner and number of people, that would get you close to the number of children. But we could have, firstborn and all that kind of stuff.
That might be
a lot of that
could be important. You it's very like you're 50 to realise that you're fed on his own anyway.
Yeah, I mean, there's lots of things.
I know what you
could think of.
Is your income data detailed enough that you can figure out for eligibility?
Comes back. I spent ages thinking of all the questions that Paul might ask. So one interesting issue, I think people, I would invite you to think about this and say, well, this is longitudinal data, but is it really a panel? You know, if you think about normal panel data, right, it's just you observe people at different years. 50 to 56, you know, what's another year? A lot of time. But here you've got two periods, and you know, the first 9 months, in the case of wave 1, it's not any old 9 months, it's a very particular 9 months. And then you've got them 2 years later, and you've got their third year of their life. And you know, when you're estimating a panel, implicitly, well, or explicitly, you've got constant coefficients. And while that might be okay for adults, or if you're looking at firms or industries or countries, you know, clearly a 9-month-old baby and their 3-year-old self have a lot in common. But in some sense, you could say, well, maybe it doesn't make sense to treat them as the same person. And this actually, if you're a philosopher, there's a famous philosophy book by Derek Parfit called Reasons and Persons, in which he argues for various reasons that it makes sense to think of people at different points of time as different people. You probably heard this radio ad for some financial product where someone says, "Dear 30-year-old me," right? And that's expressing the notion that people at different points in time are and in behavioral economics, this issue comes up. So, what can we do about it? Well, there are panel data models with time-varying coefficients. You know, just that kind of random coefficient models. That may be one way of addressing it. But I think it's worth really thinking about. Here's our
So Kevin, you're pointing this out, but you don't do anything about it at this point.
Correct. So this is the dependent variable. So just taking it first, this is the mean number of visits, 2.61. In wave 1, it's higher than wave 2, bearing in mind that wave 1 is shorter than wave 2. The variance is about 4 times the mean. That suggests there might be an issue of over-dispersion. It's not identical, because the over-dispersion is about conditional variance versus conditional mean. And obviously when you condition on variables, the conditional variance shrinks, right? Because your variables explain part of that variance. But they have to shrink it a hell of a lot for this problem to go away, and it doesn't. The other thing is that the between variance is a lot bigger, about twice as big as the within. And remember, the fixed effects models are, you know, fixed effect estimators are called within groups. It relies on within group variation. So what you'd expect to see is that when you go to fixed effects models compared to random effects, you're going to lose a lot of precision.
Right, can I ask, what's your variance when you drop those 35 units? So can you probably argue that if you drop those guys into some people you could probably argue that they're special cases and you should be on.
Haven't thought of that. Yeah, good idea.
Trade the top.
Yeah, these are really sick people.
I was wondering, is there heating there? Heating in the data, so, you know.
10,
say, oh,
15.
There is,
Yeah.
Yeah, so are you worried about that?
No, I mean, I don't know what you can do about it. I've seen that in other, you know, if you look at class size data, it's all 25, 30, 35. I don't, there's so few of them that hopefully it doesn't have a big effect.
Why that's heating at 10, because the last year you might have got 12, you know, all once a month, or once every 2 months.
But, yeah, I think I'd say 10. So yeah, it's something called digital preference. Maybe they acknowledge somebody who worked in this, Lisa Farrell did something on this, and it's cigarette smoking. People say I smoked a pack of 20.
They had
smoked
some
21. Yeah. Go ahead.
Sorry, more about arguments. So you said in wave 1, you say since survey was born.
Yeah.
But I guess older than you input the price from?
I don't know. That's a good question. I thought it
No, I
was.
can do that. I don't know. The line.
Yeah.
Go out and do it on the pigs, the white, the whites, and maybe the child size 10, 11.
Yeah, I don't know.
So,
That's a good question.
are other major ones who are 10, 11.
Yeah.
Yeah.
We'll see the consequences of dealing with that in a second. So this gets to Paul's point. So what we hear, we've graphed the income distribution for the two groups, and the green one, so the red one obviously is the medical or GP visit, and they have lower income, but there is an overlap. And that's partly because, well, this is equivalized household income, but also, you know, when you get a GP card, it's based on your, or medical card, based on your income, but your income can change over time, and it's like 3 years, you get it, so they don't just whip it off you.
Ken? So you've got equivalized household income there, right?
Yeah.
And that's, I don't know, what the scale would be something like 3.6 or
Something
something.
standard.
But in the qualification for medical card, presumably there is an implicit equivalent scale, isn't it?
We do something, yeah. Yeah.
Yeah, so if you don't have raw household income, do you?
I'm not sure. Why would it matter?
The story would be different if you re-equivalize using the equivalized income. Would you then be able to identify by household income?
It might be sharper. I suppose if your income was the more appropriate one, you could contrast
Just
it
a
sharper. But I don't think that's that important to what we're doing. Okay, that's a transition matrix for the two waves. So this is saying children who had no visits in wave 1, 34% of them had no visits 2 years later. Right? These are healthy kids, these are what we want to have. And then if you go along the diagonal, there's a fair bit of persistence. It's transition matrix for the medical card thing. So most kids don't have a medical card in wave 1, and they don't, or if they do, sorry, they don't 2 years later. So these people are ones who are kind of, well, moving up in the world, going from no medical card to either GP only or full. So you can see from the diagonal that there's not that much movement. Okay, cross-section models. So we've done these are just separate Poisson and negative binomial for the two waves. So the semi-elasticity is around 0.3. So that's saying having a medical card makes you bring your kid to the doctor. Right? If the child is covered by a medical card, 30% more visits. Marginal effect is saying that's about 3/4 of a visit. This is actually a test of over-dispersion. So this is basically testing negative binomial against Poisson, and that means you can clearly reject Poisson against negative binomial. So there is over-dispersion, but it doesn't make a whole lot of difference to the size of the coefficients. Now, panel Poisson models. We're going to distinguish between dealing with the exposure and not, and fixed and random effects. If you take these first, so here we're ignoring the fact that the first wave is 9 months and the second wave is a year. The effects are bigger for random than fixed. They're more precise. So in these brackets, these are the robust standard errors, called cluster robust standard errors. There's no such equivalent for random effects, so this is just the standard error, the maximum likelihood. And then we've also bootstrapped, because there's a heavy distributional assumption here that alpha term is a gamma distribution, so that can be a bit dodgy. So the robust standard error, the bootstrap should be robust to that. So the fixed effect does make a difference, give you a much smaller effect. This is the marginal effect, so 0.12 of a visit, as opposed to 2/3. And now, here's where the fun comes in. Here we control for exposure, right? So we assume that the frequency is proportionate to the duration of time. It doesn't make as much effect for the random effects, it makes a big effect for the fixed effect. The reason, what's going on here is that if you think about it, with fixed effects estimators, what's driving this are the switchers. And of the switchers, there are more gainers than losers. There are more people gaining a medical card than losing one. So if you like, people are going from wave 1 to wave 2, they're gaining a medical card and they're visiting the doctor more often. But that period is longer, right? So once you control for that, you expect to dampen that effect down, and in fact it dampens it down quite a lot. That effect wouldn't be as prominent for random effects, because random effects depends not just on switchers. It depends all the variable, all the medical card, whether it's changing or constant. So one thing we thought would be interesting to do would be distinguish between people with full medical card and GP visit only. So here we've just shown you the semi-elasticity, just there isn't really room for everything. Now again, for fixed effects, not many people have GP card only, and obviously not all of them are switching. That was in table 2, actually. So there is some evidence that the GP card only has about half the effect, or less than half the effect of a medical card, which is what you expect. But again, once you have fixed effect models and once you allow for exposure, those effects are going to be driven down anyway. So then we thought, what do we do about this underreporting? Because some people have very strong views about possible underreporting. So just as a kind of a crude exercise, we thought, let's say people with medical cards underreport and people without medical cards underreport, but by possibly different amounts. So all we did was we took the outcome, we took the number of visits reported by people with medical cards, they added it to 25%. So it's like, if they said they had 4 visits, we said, no, you actually had 5, right? If they underreport by the same amount, that doesn't change the coefficient, that number you saw earlier. That's just a function of the fact that it's an exponential regression.
Is that also a function of the semi-elasticity?
Yeah.
If it wasn't, the absolute difference would be greater.
Yeah, if it was a linear model, for example, it makes a difference. So up here, people with medical cards, if you like, have worse memories than people without medical cards. They're underreporting by more, right? They're forgetting, of 6 visits, they're reporting 4, whereas the folks with medical cards for 5 visits, they're reporting 4. So that obviously would bias the coefficient down. So this is telling you by how much it went down, right? That this would be the true coefficient. And so if that underreporting is going on, then this has big consequences. Of course, if the underreporting goes the other way, it'll bias your coefficient in the opposite direction. So, conclusions. So, if you look at the additional annual visits, right, just numbers of visits due to having a medical card, cross-section models, it's about 3/4, random effects panel models, about 1/2, and fixed effect panels, close to 0, slightly positive. And the effects are much smaller once exposure is fully allowed for. That's again particularly true with fixed effects. There's some evidence that GP visit cards have a smaller effect, particularly in the random effect models. All of that would suggest to us that the likely effects of extending free GP care are modest. Of course, we're using cross-section variation between individuals to infer something about a policy where you change everyone. So that is something of a leap of faith, but this is kind of all we can do. If you want to know the aggregate effects, and how many extra visits to GPs, you've got to take into account that a lot of the children were already covered. Okay, so the 70%, in this data, only 70% will be affected. Right? They're the ones who are now getting this new card. Measurement are potentially very important. We don't know too much about that. We would love to have the 5-year-old data, because obviously that would get you the span of under 6s. And I think the argument that we made about the different persons, I think arguing that a 3-year-old and a 5-year-old is the same person is a lot easier than a 1 and a 3-year-old. On that bombshell, I'll stop.
Okay, questions or comments, Nessa?